Relative to the maximally tolerated dose of Hydroxyurea, that I believe may be patient dependent. Some patients are able to tolerate 2 grams a day. Some patients aren't able to take more than 3 tablets a day, because if you push this beyond 1,500 milligrams, then they will develop hematological toxicity. So then if you truly are trying to identify if your patient is able to tolerate this up to 2 grams of Hydroxyurea for 3 months, it may not be practically feasible. So again, this may be patient dependent. But most of my patients seem to tolerate 1,000 to 1,500 milligrams. And I am, of course, on the lookout for patients who demonstrate myeloproliferation and may require a dose increase, or those who, despite adequate dosing and duration of treatment, continue to have uncontrolled blood parameters and symptoms.
Once we classify a patient as a high risk for thrombosis based on standard prognostic factors, the first question is which cytoreductive therapy, hydroxyurea or interferon. Most of the patients in the United States are given hydroxyurea. The goal of therapy these days is first to control the hematocrit, and that should be below 45% all the time without the use of phlebotomy anymore. It can be achieved in a good proportion of the patients, but we also look at other factors. Apart from normalization of hematocrit below 45, you also should look at the normalization of the white cells, platelets, symptoms, and spleen. Now, control of hematocrit below 45% cannot be overemphasized, because the prospective randomized study showed that those that did not have a good control had a high risk of cardiovascular complications, thromboembolic events, and higher number of deaths were seen in a group of patients that did not have a good control of hematocrit. So that is very important factor for really paying attention to hematocrit and maintaining that hematocrit below 45%.
Determining control of polycythemia vera by current European leukemia net criteria involves really trying to keep the blood counts as normal as they can be. So that begins with control of erythrocytosis and hematocrit, but it also certainly includes control of the white cells, meaning we really don't want them to be too high because that might increase vascular risk, but by the same token, we really don't want them to be too low as a sign of toxicity from myelosuppressive therapy with, let's say, hydroxyurea. So chronic neutropenia would clearly be unacceptable. So I really aim to have that neutrophil count be as close to that normal range as possible. The same would be true in terms of platelets. Thrombocytosis clearly can increase the risk of vascular events, but likewise we do not wish to have thrombocytopenia either from excess myelosuppression, as well as that might clearly increase risk of hemorrhage.
When I start patients on Hydroxyurea, I generally check their blood counts every week to 2, probably a little more stringent. But I have seen people develop certain hematological toxicity that could easily be preventable by dose modification. So every week to 2, and then if they are getting phlebotomy, obviously you want to do this at least twice a week, assuming they are tolerated. And then later on, perhaps in the first month or so, then you make it less frequent. I generally, the initiation of phlebotomy and cytoreductive therapy is somewhat intense because you want to get blood parameters periodically to ascertain that the patient A is responding appropriately and that you are attaining the appropriate blood parameters later on. And that frequency diminishes as you move on with treatment. The goal of treating someone with either phlebotomy or Hydroxyurea is to optimize the blood parameters. So I want the blood counts to be as close to normal as possible, with a hematocrit below 45%, with a white count as close to 10 as possible, and a platelet count below 400 or 450,000. That is the definition of complete hematological response. I can tell you that in practical terms, my emphasis is mostly on the hematocrit. So if a white count is 11,000, yes, it's not normal, but it would be difficult to justify it because you have to weigh risks and benefits also when utilizing cytoreductive therapy.
The criteria for determining whether a patient is adequately controlled with medical therapy is the same regardless of the therapy that we choose. In the setting of hydroxyurea, which is the most common that we assess that as our frontline cytoreductive therapy, that is control of the white count of less than 10,000 a platelet count of less than 400,000, and to have them become phlebotomy independent in parallel with other issues such as controlling the spleen size, improving symptoms, etc. Now, it is to achieve those goal targets of counts while the patient has a tolerable dose of hydroxyurea. And this is really the key part. Does it take a dose that they really do not tolerate to achieve those, i.e. they develop a mouth ulcer, skin ulcer, or have neutropenia, or are they on a tolerated dose of hydroxyurea but they're not reaching those treatment targets?
Hydroxyurea is traditionally the first choice for oncologist, hematologist in the United States in patients with a high risk for thrombosis that have a polycythemia vera. It is aiming to control the red blood cells, maintain hematocrit below 45%, but also to control white cells, platelets, symptoms, and spleen. This is then called complete response. First, we would like to have hematological response, but everything together, 5 factors, this is what we look at this point in time. Now, this is not possible in every patient. There is a fraction of the patients, perhaps 20 to 25% of the patients, that do not have a good control of the blood cell count, symptoms, or spleen that have a polycythemia vera that are treated with hydroxyurea. The dose needs to be optimized to the highest dose that would do the job. In other ways, you can do the maximum tolerated dose or the maximum safe dose that would provide the benefits. If we cannot provide the benefit using the maximum dose that is tolerable for the patient, then that patient has uncontrolled disease. That is easy to understand. If we cannot, with the maximum dose that is tolerable by the patients, control the red blood cells, white cells, platelets, symptoms, and the spleen, that patient is not responding very well, and in fact, it is in need of alternative option, which would be perhaps interferon or a JAK inhibitor, ruxolitinib.